I really got involved in COA probably about 2 years ago. We're having trouble with PBMs and DIR fees. DIR fees are direct, indirect remuneration. PBMs had originally started out mainly on, they were doing diabetes, they were doing high blood pressure, things like that. And they would grade you at how well your patient did on the high blood pressure, how well they did on their blood sugars and things like that. And the lower your grade was, the more money they took back retroactively after you've already dispensed the drug. And it works decently if you have diabetes or you have something that you can measure. For oncology, on the specialty groups, they did it almost entirely on adherence. Well, the adherence for somebody on a diabetes drug versus somebody on an oncology drug, two different things. Diabetes, you can pretty well take it every day, 365 days a year, and have high adherence. When I looked at my top 5 drugs on oncology, we had breast cancer, we had multiple myeloma, we had 5 drugs that affected your blood counts. And when you look at the package insert, it automatically said, well, you're 33% of these patients are going to have to be held because of low white blood cell counts. Being the working pharmacist, I knew better. I knew my patients, and I knew that we actually didn't have an adherence problem. We had a problem with side effects, which was documented in the literature. I actually just got kind of mad about the whole deal and decided, after 35 years of being out of pharmacy and never writing an article before in my life, I wrote an article. And when I sent it off to COA, COA was like, yes, this is what we need. This is like the boots on the ground information. And they helped me get it published. It's still a huge issue. They're still taking lots of money back. Starting in 2024, the retroactive DIR fees will be going away for Medicare patients. Not for everybody, but at least for Medicare patients. My name is Daryl Williard, and I am Community Oncology.